Hello, my name is Ioana-Irina Rezuș, and my PhD title is the Management of Pancreatic Cancer from Diagnosis to Treatment. I'm a first-year radiology resident and a bilateral PhD student with a vision for a better management for patients with pancreatic cancer. And for that, my mission is to assess new diagnosis and treatment methods and implement them into healthcare. I have two ongoing projects, both of them under the type of a systematic review and meta-analysis. My first project started in September last year, and it is about the efficacy and safety of therapeutic procedures for chronic pain in patients with unresectable pancreatic adenocarcinoma. Pancreatic adenocarcinoma is currently the sixth leading cause of cancer-related death, and it is expected to become the second one by 2030. Unfortunately, more than 80% of these patients have unresectable disease, and almost as many have pain at the time of the diagnosis. The available medical treatment consists mostly of opioids and is still associated with inadequate pain relief in more than half of these patients. But since there have been emerging more interventional ways to address this pain, we aim to find out which one is the most efficient out of them. So we raised the question, which method is more effective and safer for pain management in patients with unresectable pancreatic cancer, with the population to study being adult patients, the intervention and comparators being any type of pain management. Our primary outcomes are pain relief and quality of life, while our secondary outcomes are adverse events, survival, and analgesic drug use. And we chose to include only randomized controlled trials. Our hypothesis is that interventional methods can provide a better chronic pain management for these patients. We performed our search key on 29th of October last year, with the search key you can see on the left side of the slide, in 5 major databases, and you can see in brackets the number of hits on each database. We started our screening with almost 5,500 articles and ended up with a number of 21 eligible full texts. Our primary outcome was pain, as pain is one of the most debilitating symptoms in patients with pancreatic cancer. And we wanted to assess this pain at baseline at a different time points to see the dynamic of pain under each type of treatment. And our treatment groups were either one-time interventions, such as different types of celiac plexus neurolysis or high-intensity focused ultrasound, or continuous treatment of daily opioid intake. In our studies, the pain was measured on the visual analog scale, which ranged from 0, meaning no pain, to 10, meaning the worst pain possible. And when we analyze the baseline pain values, we can see that in all of the study groups, the pain was between moderate to severe, with values around 6 to 7 out of 10. However, when we look at the dynamic in time, we can see that at 4 weeks in all of the study groups, the pain significantly decreased. However, there is not one intervention better compared to the others. When we look at 8 and 12 weeks, we can see that again, in all of the study groups, the change was similar, meaning that the pain increased, but with now no big differences between the groups. We could say that at 12 weeks, the endoscopic ultrasound-guided neurolysis performs better than the others. However, the low number of studies included restricts us from drawing a definite conclusion. But it is important to assess the results of the pain in the landscape of adverse events. So we chose to compare the adverse events that are most commonly associated with celiac plexus neurolysis. And here we have results for diarrhea, which was defined to be a transient adverse event lasting to a maximum of 3 days. And we can see that 23% of the patients that had percutaneous neurolysis developed diarrhea, while only 11% of the ones with endoscopic ultrasound-guided neurolysis developed diarrhea. And the same can be seen for the cardiovascular events, who were defined as orthostatic hypotension or hypotension lasting a maximum of 3 days after the intervention and with no inotropic support needed. And again, there were more cases in the percutaneous celiac plexus neurolysis group, with 26% of the patients developing these cardiovascular events, while only 13% in the endoscopic ultrasound neurolysis group. The strengths of this study are that we included a large number of diverse procedures, and we measured the outcomes at multiple time points, and we included only randomized controlled trials. However, we had a low number of studies available, and there was a high heterogeneity between them, and also the lack of clear gold standards for pain and quality of life assessment made our analysis very difficult to conduct. But to conclude, we think that minimal invasive procedures provide pain reduction with fewer associated adverse events, and between them, the endoscopic ultrasound urolosis seems to have a better overall performance. And it is important for practice, as these interventions should be considered more often and earlier in the management of these patients. And for research, it is important to have further RCTs that compare not only one intervention to the standard of care, but two interventions between themselves, and also one repetition to multiple repetitions of the same intervention. At this point, our study got rejected twice by 2 articles, but Peter Heggie says that to elevate your success rate, you first need to elevate your failure rate. So since we did the first step, we are now aiming to submit to UEG journal next. And the second topic, it is about the diagnostic performance of different imaging techniques in pancreatic cancer diagnosis. As mentioned, pancreatic cancer has a very poor prognosis, with the resection being the only chance of cure. If you look at the overall 5-year survival rate, it is only 4.6, but if we take into consideration patients with tumors smaller than 2 centimeters, then this 5-year survival rate is 80%. So it is highly important to detect as early and as correctly as possible these tumors, and usually we use imagistic methods such as endoscopic ultrasound, CT, or MRI. So our aim is to find the best performing imaging technique in the detection and staging of pancreatic cancer. The question is, which imaging technique has the best diagnostic performance for pancreatic cancer detection and staging? And we will stratify the population in adults at risk for pancreatic cancer, so asymptomatic, and patients suspected of pancreatic cancer, so symptomatic. Index test will be any kind of radiological examination, with the reference test being pathological examination when available, with the outcome of performance detection and staging of pancreatic cancer. And we hypothesize that one investigation provides better results compared to the others. Of course, the main clinical implication will be an increase in the survival, while for the policymakers, it will be important to decrease the number of unnecessary investigations. The search key was performed this July, with the search key you can see on the left side. And it is important to underline the last domain, that we will include only randomized controlled trials or direct comparative trials. And right now we are in the phase of full text screening. And we hope to finish this phase by the middle of September. To conclude, I have 2 ongoing projects, which I hope I will finish both of them by the beginning of next year. Thank you for your attention, and I will leave you with a quote from George Bernard Shaw: "Don't wait for opportunity, create it."
Thank you very much for the presentation. Congratulations. Any questions from the floor?
So regarding the first presentation, I noticed you included only RCTs in your study, but did these patients with unresectable pancreatic cancer, did they receive any kind of treatment along with the pain management? Did that treatment influence the efficacy of the pain management?
You mean treatment if any kind of...
Radiotherapy, chemotherapy?
In most of the cases, they were defined as patients with no possible for any type of treatment, like palliative care treatment.
Okay, so no kind of interaction with the tumor?
No.
Okay, thank you.
Thank you. What was used for the ablation, either percutaneously, US guided ablation?
Alcohol. Alcohol between 90% to 100%. And the thing is that the dosages differed between studies, but and also the percentages. In all of the articles, it was alcohol. But then in most of them, it was alcohol 90% to 100%. There were some articles with 75%, and then the dosages were very different. Some of them 10 milliliters, some of them compared even 10 to 20 milliliters, and this is, I think, one of the reasons why the heterogeneity is so high.
Okay, if the disease is locally advanced, we tend to use stereotactic radiotherapy. Did you find any evidence for that to decrease the pain also?
There are studies. The problem was that they were not randomized controlled trials, so we couldn't include them in the analysis.
This is something very interesting also. And the third question, have you seen anything when you were doing all this analysis regarding the PET MRI? Because we do have that, and we have done this procedure, the PET MRI, combined PET MRI scans in about 180 patients. And it has altered the treatment plan in about 40% of the cases, because it picked up a lymph node, which we didn't suspect based on the CT scan, or showed distant spread and things like that.
The problem was with the first study that we first wanted to do a network meta-analysis, so we focused only on RCTs. So when we didn't see an RCT, we excluded, because this was the exclusion criteria. Looking back, I would like to reread some of the articles, because I think there is very interesting data which is not published in RCTs. But
okay, thank you very much. Any other questions?
My problem is that there are, I think, a couple of papers. I'm talking about your first project, which compared the endoscopic US-guided neurolysis with the percutaneous neurolysis, and the first one is definitely better, and have less side effects. So my question is, what new results you have as compared to the data already having in the literature with your meta-analysis?
It's true that at the beginning we hoped to find more RCTs with newer techniques, such as microwave ablation, cryoablation. This was what we hoped. However, there is some interesting data also in the survival that we analyzed. The survival, and we saw that, for example, with the percutaneous neurolysis, somehow the survival was lower than the one with endoscopic, and there is this high-intensity focused ultrasound, which has interesting results, and the survival rates seem to be higher. It is true that the patients that had this high-intensity focused ultrasound had a baseline quality of life better than the rest. But there are some new results, and also I checked the guidelines, and they cite just one previous meta-analysis that compared, I think, neurolysis with opioids, but they don't really specify which type of neurolysis. So I think it could be useful to be some extra evidence added to the guidelines.